Thanks so much, Terry, for that introduction, and it's great to be here. Great to have the 5th meeting of this roundtable underway. We're almost a year old, so we're beginning on our journey. I'm really honored that the planning committee asked me to actually set this up in a substantive way. We will drill down, as Terry has just said, during most of the day. We're going to drill down into some of the financial mechanisms that he outlined. But before we do that, and for those of you that know me, I sort of travel at the conceptual higher level. I'm going to try to set this up in a broad way before we go down that path in this little overview called Paying for Population Health Improvement. And the forward button here is not working. On the slides, sir. There. Okay, thank you. Which one's that? Okay. So I'm going to touch on 3 parts of this. How much do you need, and where would you put the money? Where would you get it from? And at the end, a little bit provocative about, I hope, can local investment guidance be developed? This is a map in 1979 of age-adjusted mortality rates across the country. This is the same map in 2008. Actually, the mean has gotten better, which you don't see on this map, but the disparities persist, the geographic disparities. Not, as a matter of fact, statistically, the disparities have actually gotten worse. This is a slide from our first roundtable discussion, and this is the OECD slide that shows sort of where we rank in the world in our life expectancy, and this one in relation to the vast amounts we spend for health care. We are performing poorly in our health system, and it's the mission of this roundtable to catalyze action to do something about it. And this is an urgent task. It's actually 17 years ago, I wrote this book called Purchasing Population Health, Paying for Results. And right inside the front cover, it says, the fundamental assertion is that population health improvement will not be achieved until appropriate financial incentives are designed for this outcome. That was 17 years ago, and we've had some progress, as we'll hear about it today. But we still have a long way to go to essentially change the color of those maps. I am sick and tired of looking at those maps. And I'm old enough to be able to say that because I haven't been looking at them for a long time. George and Terry indicated that we have a series of drivers of that vision for our roundtable, and today we are particularly focusing on the resource issue, but in the awareness that it's in the context of all these drivers that these will work together to sort of improve these outcomes. And actually, Terry and George already covered this point. I mean, we have the planning committee developed a broad definition of resources for their general work, including a variety of points that George has already mentioned. But today, we will be focusing primarily on financial resources, and particularly some unique private sector funding mechanisms that can help us, particularly as we try to invest more in the social and environmental determinants of health. So here's what I'm going to talk to you about in only 20 minutes. To improve overall health and reduce or eliminate health disparities, significant new and reallocated resources of many kinds will be required. We can't do this any other way. While philanthropy and public pilot funds are critical for testing new sources and ideas, developing and aligning dependable long-term revenue streams is essential. We can start by reallocating savings from ineffective healthcare expenditures, but we will need to go beyond that to expand to health in all policy investments as well, especially finding the sweet spots where the core missions of other sectors align with health improvement objectives. New evidence is badly needed regarding the relative cost effectiveness of the different investments, but we can't wait decades to act. And finally, and this is a mouthful, and I'm going to return to this at the end of the talk, I'm going to challenge this roundtable today in this little talk. I think we could add value by leading the call for the development of, and in yellow, this is the mouthful, optimal cross-sectoral financial investments or policy strength benchmarks that are tailored to individual community outcomes and determinants profiles. That's a bit complex, and I'm going to return to it at the end, but I hope you get the general idea right now. So quickly through these three parts, how much is needed and for what investments. Victor Fuchs still is an emeritus professor of health economics at Stanford. In 1974, he said this: how much then should go for medical care, and how much for other programs affecting health, such as pollution control, fluoridation water, accident prevention, today he would say the social determinants of health, and the like. There is no simple answer, partly because the question has rarely been explicitly asked. And shame on us for still being in that position to some degree, not that we haven't made some progress. The terminology health expenditures can be and is misleading. This is from a blog post I wrote in Health Affairs blog in 2011. Do they really mean health expenditures? Our national health accounts report expenditures currently of 2.7 trillion, but they really only count health care and governmental public health. The total cost of health is, question mark, much probably, greater if the cost of the non-medical determinants are included. So we don't focus, when we say health expenditures, we're only, in relation to the accounts, the way we report them, we're only focusing on a part of the story. We do not know today what the total health budget needs to be to change the colors of those maps. It would include adequate resources for public health and less healthcare spending. And I put in parentheses here for our future consideration, do we agree with the IOM report from last year that parity with OECD health spending is a goal that we should focus on and talk about? Plus, that share of the other sector investments that are at the same time health promoting as they accomplish their own objectives within the sectors of housing, education, economic development, all the ones that we are concerned about here. I mean, we know a little bit. It's not like we haven't thought about this. I mean, as Terry mentioned, the IOM report, Investing in the Healthier Future, last year talked about the needs for funding in governmental public health, building on the Trust for America's Health, a 2008 report where they talked about a $20 billion shortfall, and the IOM committee, building on that, actually mentioned a more conservative shortfall of doubling current expenditures at that time from 11.6 billion to 24 billion. That's just within the governmental public health area. It's important, and we've had some estimates about what needs to be done. There's really disappointingly much less evidence about what we need cross-sectorally. And actually, the only decent paper that I know of is this one in the British Medical Journal by Bradley and colleagues in 2010. And they actually looked at the ratio of social services to medical care spending across OECD countries. And in Europe, it's like a ratio of 2.0, and here in the United States it's 0.9. Now you can't make causal inferences from those numbers, but it gives you a sense of where some of the gaps might be in relation to our poor performance. We heard at our first workshop the paper talking about America's health dividend, where they actually, in their own way, looked at the savings that could be identified within healthcare. And in that particular report, they only focused on the part of it that would accrue to the public sector. In that report, that was $337 billion. And then they actually went ahead and said, if we were able to capture that and move it into more effective investments, these are some of the places it might be put. Again, this is not rocket science empirical analysis, but it's a sense of direction. 168 billion in debt reduction just to improve the economy and create more jobs. 104 billion in education programs like universal pre-K and smaller class sizes and smoking education and Head Start, some of those programs where there is an evidence base. And then other investments in infrastructure like safe streets and Job Corps and food stamps. So again, this is the list of the kinds of things that we need to be developed, even though we can't say this is the only way to do it or the best way right now in 2014. This is a slide that I've used for 10 years in teaching, and I've never published it because, again, it's not have a strong evidence base. But if I were czar and even only the modest 20% of savings from in healthcare could be achieved, where would I put them? And this is actually several years, this is a 6 or 8 year old slide. I've kind of said 100 billion of the 500 billion, 100 billion in covering the uninsured, which is essentially sort of what we did in the ACA. Another 100 billion in public health and prevention broadly writ, which is a lot more than even what TIFA and the IOM estimated. And then the other 300 billion, I label it in the social factors, but in these other areas that we know to be health promoting. But again, that's just the view of one experienced emeritus professor, but it's a judgment. If I were czar, that's what I would do. Okay. Now, even if we could figure out what the right equation was, what the right formula is, this is a big country, and different places need different investments. And so it gets worse. It gets more complicated than that. So this is actually a little slide I put together over the weekend. This is from America's State Health Rankings that came out last in November or December, I believe. So I picked 2 states that are doing very well in the rankings, North Dakota at 9 and Utah at 6. Those are probably essentially the same, statistically, they're really up there doing well. But look at the determinants that they have in their state as well. And the point of this slide is that different places today, different states, and it would be true for communities, can get to the best health we can have in different ways. And realizing that, your investment profile in those places would have to be tailored to that, which makes it more complicated, but important to keep in mind. And I'll come to that at the end, what that means for us. You would think, and I thought, that the colors of those maps have to have been produced by differential patterns of financial investment and policy strength over time to sort of produce those results. And you would think that if you could use that experience of that variation to look at the community level and look at those investment patterns and get some idea about what would be optimal for investing in the future. There's been a little bit, I only found 3 papers at the state level, which actually are econometrically robust and find findings that they have are in the right direction that we would expect of what kind of factors. But states are so huge that there's not enough variation in state analysis to allow you to really dissect the robustness of that. We, in Wisconsin, Tim Casper, who used to be our state budget director, we actually he looked in 15 Wisconsin counties to see, is there enough data available at the county level to really look at per capita investments in the different determinants like Medicaid, like early childhood, like Head Start, like economic development. And even in a state like Wisconsin, at least in 2010, we found that the answer was no. You know, there really was too much variation and too much imperfections in the relative accounting systems to really allow that to be done. So that's a huge challenge for us, you know, to be able to move forward and dissect out what might really work. I think this roundtable should take the lead in getting such estimates developed so we know what our health budget needs to be. How can we operate without knowing what our budget really needs to be? And that's also a role in our driver diagram for our science-informed interventions and research activity, which hopefully we can have some influence in making these more robust. Part 2, where can new investments come from? This is from a paper that George and I have in press. And, you know, there's not any rocket science in what these possible sources can be. One, as we've already talked about, could be from savings in healthcare. And we're going to be talking about some of that today. Community benefit reform, the possibility of ACO shared savings. Last year's investing in the public health report from the IOM called for the possibility of transaction taxes on healthcare. So and a lot of that stuff and other things are what we'll be talking about here today. Health in all policies, more health from what we're already spending in other sectors, including some of the community development opportunities that we will be talking about here today. From government, from foundations, from businesses understanding the business case. All of these sources need to be considered as we look for the resources we need to improve our poor performance. I'm only gonna briefly mention two. I've been particularly interested in the community benefit question the last few years, that obligation that nonprofit hospitals have for their tax exemption. Most people, I think, still believe that that's primarily charity care. And we now know, because of the Schedule H data that's available, that actually about 25% is for charity care and 5% is for community health improvement. And most of those, the rest of the expenditures are essentially Medicaid discounts or other money-losing services. This is probably a $40 billion per year IRS requirement that potentially, not completely, but could be marginally redirected in other ways. And I mentioned business before, and this is just a list of sweet spots for business. It's actually a list that one of our members, Kathy Basie, owns the intellectual property of, but you'll find it in a paper on our website that came up last year on the Roundtable's website. But it's not just healthcare costs or workforce productivity. There are a whole variety of other sweet spots that we can explore in the business sector. And I look forward to her leadership and our work group on business during the year to sort of develop that more fully. What we need are dependable revenue streams. I'm old enough, probably some of you don't know, but there used to be a poster back in the 60s called "What if they had to have a bake sale to build a bomber?" It's not. This is a voluntary effort. Is not going to get this done. I mean, this is a sixth of the nation's economy. We need to move beyond grants and short-term appropriations. That's not that those are not important, and a lot of our work builds on them. This roundtable is funded by those, so don't knock that. But we need to move to dependable, I'm going to say, formula sources. and now I'll get in trouble for what I listed here, but like crop subsidies or mortgage interest deductions or Medicare medical education payments. I mean, these are not annual grant renewal items. I mean, they're controversial, they get debated in Congress, but as they go along, you know, $1 or $10 or $100 goes in the pot every day, you know, to do this important work. And for those investments in other sectors, like early childhood development, and isn't it remarkable how much activity is going on around the country about that these days, we need to add our political clout to their efforts, those sector efforts for win-win opportunities for those kind of funding mechanisms, which will come and help us be health promoting at the end of the day. And then actually this is there's efficiencies to be had as well, and one of our roundtable members, Ray Baxter, wrote this paper called Making Better Use of Policies and Funding We Already Have. So there's also, we've got to look in our own house and make sure that that's in place. So finally, I think we need to move beyond determinant benchmarks to investment benchmarks. There's a decent effort out there about what's effective, at least within health care and public health, and in some of the other sectors as well. And we would build on such important work like the CDC Community Guide. This is actually a little derivation of that we have in our County Health Rankings and Roadmaps program, What Works for Health, where you can sort of find the evidence about relative effectiveness. But what we don't have is the same kind of evidence about cost effectiveness and the benchmarks that we might strive for to change the colors of those maps. This is a little snapshot. In the county health rankings, every county has a profile, and I just did this snapshot out of a top corner. So there's mortality and morbidity and all the determinants, education rates and poverty and healthcare quality. In addition to the numbers, there is in here a national benchmark for the determinant. You know, so what's the benchmark that you might think about for high school graduation rates or smoking rates or whatever? How about a column next to that about the investment benchmarks, about how much per capita spending on that item, or the policy strength needed in order to get the determinants to those levels that they need to be in order to get the outcomes to change. So I think that's a generation of activity that maybe we could stimulate here. And we have to keep in mind the North Dakota-Utah story, that it won't be a single solution for every place. And so it probably has to be some sort of a dynamic local tool that allows that thinking and policy discussion to go forward. And actually I blogged on this a year ago called Locally Customized Population Health Policy Packages. But that's where it is. It's a blog idea that needs to get some meat on the bones if the idea has merit. So this is why I had that fifth mouthful at the beginning of the talk. I think we could add value by leading the call for the development of optimal, cross-sectoral financial investment or policy strength benchmarks, which are tailored to individual community outcomes and their determinants profiles. What we need is a pay-for-population health performance system, a system that has a coordinated effort across determinants between the public and private sectors, as well as the financial resources and incentives to make it work. In the same paper that I mentioned before that George and I have in press, we've actually expanded that thinking a bit in a paper titled A Community Health Business Model that engages all partners in all sectors is necessary for population health improvement. Another way of saying the same thing. So for me, and I'm almost done, in a resource limited, this is the population health question. I mean, this has been on my website for a decade. In a resource limited world, nation, community, whatever, What is the optimal national and local per capita investment and policy strength across sectors that's needed to improve overall health and reduce disparities? And even though today we're focusing on the resource driver, that's only one part of the picture. And all of our drivers for this roundtable have to work in concert to sort of make that happen. That's my last slide. As I was coming in, however, I remembered a little quote that I wanted to end with, a little paragraph. You may recall Elliot Richardson was a secretary of HEW and an attorney general that distinguished himself by resigning during the Watergate scandal. He wrote a book, and he's always been one of my heroes. He wrote a book in 1996 called Confessions of a Radical Moderate. And there's a little paragraph in there I'm just going to read. He's talking about being the head of HEW and trying to get some innovation going. And he says, here he says, though varying in language and emphasis, their responses, and he's talking about his economists and the staff, came down to this: it's too hard to do and measure the things you're talking about. Each time they said this, I would reply to them, I know it's hard, but this doesn't mean it's impossible. If it's also important, why don't we get started? And then he says, we didn't get started then, and the task is even more important now, so why don't we get started now? Thank you.